All right, so we're going to talk about swallowing and Parkinson's disease today. So what are we going to cover? We're going to look at how we swallow and what does a normal swallow look like? It's something that we don't usually think about because we do it so many times a day that we hardly ever pay any attention to it. We'll have a look at the Parkinson's swallow and what that tends to look like, and what are the things that can go wrong, or what are the implications of that when things start to not work as they should. We'll talk about the ways that myself as a speech pathologist manage swallowing issues, and we'll talk about medications, because this is something I get asked about, I think, 100 times a week. How do I get these medications down? And we'll talk about some tips and tricks around that. So swallowing, it's a pretty big deal in our profession, and obviously, you know, speech pathologists trained in this area would see hundreds and hundreds of swallows a year. And it's so important that in actual fact, our profession has a day where we try and raise awareness around swallowing issues. Swallowing issues we call dysphagia. And more than a million people in Australia would have some degree of swallowing difficulty, whether it's very mild right through to very, very severe. Roughly, you know, people would swallow around 700 times a day. Again, it's something we do where we hardly ever think about what we're doing. We swallow our saliva automatically. We hardly ever think about it until something starts to go wrong. We use 26 muscles to swallow. So it's a very highly coordinated process, which is controlled by the brain. And you'll see some statistics down the side of that poster there put together by Speech Pathology Australia. We've actually got here 84% of people with Parkinson's at some point of their disease will have a swallowing issue. Again, can be very mild right through to very, very severe. So let's have a look at a swallow. Here we've got a video. It's an X-ray. I don't know if anybody has had this done before, but it's called a video fluoroscopy. It's basically a side shot of our face. So sort of this side here, you'll see that you have got the jaw, the tongue, the teeth, and down here we've got the swallowing pathway, and we've got here the Adam's apple or the hyoid bone. And down here, we've got our voice box and our airway. So you'll see a black blob in the mouth, and it will happen very quickly because the swallow happens really fast. And you'll see a black blob coming into the mouth, and then all of a sudden it will trickle down into the esophagus and down to the stomach. So if I press play, you should be able to see that video. So you can see chewing, 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 getting the food together, and then that black blob goes really fast all the way down, and then again, a little bit more passes through. So that process happened really fast, and that is what happens with a normal swallow. That process happens without a whole lot of thinking to be done, because a lot of it is just done automatically and controlled by the brain. We usually break up this swallow into 3 phases, and we'll talk through that now. So we've got here phase 1, phase 2, and phase 3. You'll see here, again, we've got the lips, the tongue, which takes up a huge amount of the mouth space. We've got teeth, we've got the nasal passage, we've got down here the airway and the voice box. We've got the esophagus, which runs down the back, and this green blob is the food. So you can see that there. The process to start with is actually something that we are conscious of. It's a voluntary process. So this is where we chew the food, or we hold the fluid, and we move it back into the back of the mouth to get it ready to swallow. Saliva is mixed with the food at this point to try and get it into a nice sort of cohesive bolus that we can move back into the back of the mouth. Our lips close so nothing falls out the front. And as I said, this process is the part where we are conscious of what we're doing. It's the next two phases of the swallow that are taken over by the brain. So this second part of the swallow is actually where the food or the fluid is taken right back into the back of the mouth, and the epiglottis comes across and closes off our airway. So this is really important because we don't want any food or fluid getting lodged or taken down that airway pathway. We want it all to be pushed all the way down to the esophagus. And we want it cleared away from there too. We don't want any residue hanging around that area because that can, as soon as we breathe in after we swallow, that can get sucked down into the airway. Because when we swallow at this point, we actually stop breathing for about a second. So to make sure that the airway is really closed off and safe. And then the last phase is you'll see that green blob has, disappeared right down into the esophagus and it's heading down into the stomach. At this point, we really need to be making sure that these two little sphincters, we've got one at the top and one at the bottom, close off and clamp, and to make sure nothing can come back up. And that's often what we find in terms of reflux. So if you have reflux or you've heard of that word before, that's where that issue happens, because those two clamps aren't clamping off to keep the food and fluid down. So that's what happens in a normal swallow. Every day we do it, as I said, up to 700 times just with saliva, but we do it more when we're eating and drinking. So we're doing this process hundreds and hundreds of times a day. And it needs to be a really highly coordinated process. So it doesn't take much for something to go wrong. So what does it look like in someone with Parkinson's? So again, we'll look at these same three phases of the swallow, and let's think about, in terms of Parkinson's, what that might look like. So at the oral phase, so at that very beginning phase where we're chewing, we're trying to break down the solid, we're trying to hold fluid in our mouth, we're trying to get that food or fluid back into the back of the mouth to trigger that swallow. If we think about Parkinson's, often that coordination of chewing, trying to break down the food, trying to get that tongue to work and to push that food back and coordinate it into that ball that we need for it to go back into one nice sort of particle that we can swallow down. So often we'll find that there's a lot of residue that can get around the mouth. It's hard to bring it all together. And particularly if we have a dry mouth, it makes it even harder because we don't have that saliva to sort of help to bring all of that together to help to form that one ball that's needed to then do that next phase of the swallow. Sometimes we can get some spillage out the front if our lips or our closure of our lips is not strong enough. So we can get some spillage out the front of the mouth or at the side of the mouth. Sometimes in really severe cases, at this really early stage of the swallow, people can't actually get any of that food or fluid back. So it just sits and there's no coordination of the muscles. There's a lack of strength there to actually coordinate enough to get that back safely. So that second phase of the swallow, so here where we've got the brain taking over that process, where that reflex kicks in, sometimes that reflex is slower to register. So that message coming from the brain to the swallow is a bit delayed. And so you'll find that you've got that food sitting in the back of the mouth, but that trigger has not happened yet. And it can take a little bit of time to kick in. We can find that the muscles aren't strong enough. So often, we find that the muscles trying to push that food down are not strong enough to clear everything from that pathway. And so we tend to get a lot of residue that hangs around in the throat. And as I said, we tend to stop breathing for about a second in that phase of the swallow. So if we have residue that's in the throat and then we go to breathe in, that can get inhaled into the airway. And obviously that can be quite dangerous. We can also find that the muscles to close off the airway, so that epiglottis and the vocal cords help to protect the airway as well, are not working again in a responsive, quick enough way to protect the airway. And so we can find that things tend to leak into the airway. We'll talk about that a bit more. And in that last phase of the swallow, again, we can find that the muscles aren't moving the food through that pathway enough or quick enough, so that you can get a lot of feeling of sticking of food or indigestion, or that reflux that I was talking about, where the clamping off is not happening, and so therefore you're getting that backflow of food and fluid. Okay. So if we have dysphagia, what are the consequences of that? So first of all, aspiration. I'm not sure if anyone has heard of this before. You probably have, because it's a pretty scary word, and it can be a little bit scary to think of food and fluid going into your lungs. But this is something that, as speech pathologists, we are very heightened and trained to pick up, because obviously the consequences of someone aspirating can be quite serious. Aspiration pneumonia, what we call food and fluid going into the lung, is not something that you can catch from other people. It's not a pneumonia that is contagious. It's purely because the swallow isn't working and the food and fluid is getting into that airway, getting into the lungs and settling and causing inflammation. And people will be susceptible for many, many different reasons as well. So I have seen people that can aspirate quite a lot, but they never get sick from it. I can see people that aspirate tiny bits and they get very unwell. So it's a balancing act as well, around trying to figure out what's going on for that individual person. Unintentional weight loss. We think about having trouble swallowing and coughing, choking, finding it hard to chew, becoming fatigued, you don't have much of an appetite, just general discomfort when you're eating and drinking. You tend to then eat a lot less, or you avoid meals, or you're sort of eating very, very limited amounts of what's sort of put in front of you. And therefore you'll find that the weight is starting to drop off gradually. Choking, obviously something, again, quite serious, and we want to put in all the strategies to make sure that this doesn't happen. But obviously when we've got issues with coordination, we've got issues with muscle strength, and issues with protecting our airway, choking is something that can happen. And we want to make sure that we can upskill and educate people around, I guess, how to avoid that, but if it happens, what to do as well. Multiple hospital admissions, and this, again, because we might be getting chest infections on a regular basis, we might be losing weight and becoming quite malnourished, dehydrated because we can't get enough fluids in. We tend to find that people sort of start to bounce in and out of hospital with different sorts of issues. And obviously going into hospital and getting treated, say for an aspiration pneumonia, you clear up that infection reasonably quickly with some antibiotics. It's the flow-on effect from that. So having a hospital stay for somebody can have implications in terms of having a fall in hospital, catching another infection, not getting your medications on time, and maybe getting a delirium, getting confused. So it can help initially to clear up that infection. It's the flow-on effect sometimes for people when they're admitted to hospital with an infection that we want to try and avoid as much as possible. So we want to try and manage it in the community as best we can so that we avoid people bouncing in and out of hospital and being, I guess, prone to some of those other things that I mentioned, falls, deliriums, other infections, that type of thing. Generally poor quality of life. If you've got people that are really struggling with their swallowing, getting lots of chest infections, losing weight, becoming malnourished, you'll find that people will start to become weaker, not being able to walk as much, maybe starting to feel a bit low in their mood, just generally not enjoying their food and fluid, not participating in meal times with families, that sort of thing. And we've talked about malnutrition and dehydration. Again, if we're having a lot of trouble swallowing, we tend to avoid or eat and drink less, and therefore we can become dehydrated very quickly and we start to lose weight, we can become malnourished. So aspiration, what does it look like? As I mentioned, it's not a pneumonia that we catch from an airborne disease. It's something purely from food and fluid going down into the airway. Now, it can be something that we react to, so we cough, and it happens to everybody. I know sometimes if I take a big sip of water or I'm not concentrating, I can cough, but that's my body's natural response to clear that from my airway. Sometimes people don't have that response, and therefore they're not able to cough. Or they're not able to cough enough or strong enough to clear that from their airway. And so therefore it goes, and once it's gone down past the voice box, it's gone. So it'll settle into the lungs. So let's have a look at what it looks like on this video here. So we'll see the swallow again, we'll see that blob coming down through the esophagus, but this time we'll see things coming into the airway. You'll see a black line that comes into that voice box. So you can see here the blob, and it goes really quickly. And again, so that's a really good swallow. You see it all cleared down. Now this one here, you'll see that trickling here, and all of a sudden it's going into the airway. You can see that black line. You'll see it again here. It'll come down and we've got this line. It's taking a long time for that swallow to respond. And you'll see that line of fluid going down into the airway. And that's what we're talking about with aspiration. So how do we manage dysphagia? Well, there's many things that we can do. So you might have heard about modifying diets and fluids, and this is obviously one part of the puzzle. It's not everything, but it certainly can help people to eat and drink more comfortably, eat and drink more safely, and eat and drink in larger quantities, because it is easier to manage something that's modified. So we can modify fluids and we can modify diets, and we'll talk about that in a little bit more detail. We can look at positioning, so looking at how we can increase more comfortable positioning. We want to be sitting upright in a really well supported chair. We want to be able to access the table and access the meal really well. And we know for Parkinson's, it's hard to get in that comfortable position or sit for long periods of time. So it's looking at how we can maintain that positioning for that meal time to make sure that we're getting the most optimal positioning for that person. We can look at different types of equipment. So whether that's, cup, straw, cutlery, plate guard, those sorts of things. Alternative feeding options, and this is something we look at for someone on that very, very severe end of the spectrum. And as I said, swallowing you can have from very, very mild right through to very, very severe. So when we're talking about alternative feeding options, we're talking about things like PEG tubes, where we can put food and fluid down the tube, and even medications. And it takes that pressure away and that need to have to try and struggle through every meal to get enough nutrition and enough hydration in and to get medications in. It's taken away and put through the tube. My take on that is always, if someone has a PEG tube or we're going down that pathway because the swallow is getting quite severe, that we always try and maintain some form of oral intake, because that's really important for your oral hygiene, for your saliva management, and just for quality of life, that having that taste and pleasure of something that you enjoy is really, really important. So coming up with a plan that works for that person, having some really clear safety protocols in place around how we manage when someone's being fed through a tube, making sure that we can still offer something orally is really, really important. Looking at timing of meals, so when someone might be on or off, that will make a big difference. Whether someone's really fatigued. Again, nausea. Often there's patterns with that around particular timings of medications and things like that. So looking at meal times around some of those things. And looking at, could we do something like, if by the evenings, that's your worst time when you're tired, should we swap the bigger evening meal to the lunch meal and actually having that in the middle of the day when you're good, and having something much lighter and easier in the evenings when you're really exhausted and really can't be bothered. So speech pathologist, we always are liaising with the GP, with gastroenterologists, with dietitians, with specialists to try and come up with a plan. And in particular, when we're looking at very severe dysphagia, then it's obviously a whole team approach. We need to come together to be able to come up with a plan that's going to work for that person. There are some exercises that can help at times, often very early on in the piece. If someone's experiencing some issues with their swallowing, we can do some exercises for the tongue or the lips or the mouth. Voice exercises can help with that closure of the airway and trying to get some good protective mechanisms happening to avoid aspiration. And again, we just sort of consider that on a case-by-case basis, depending on what that person is experiencing. And a video fluoroscopy, like what we looked at before with the x-rays. If we're not quite clear, we can't get a picture of what's happening, then perhaps that's something we need to look at. And that would be through the outpatients department at the hospital. So modified diet and fluids, this is what we work off as speech pathologists. This is the international standard for diet and fluids. So this was put together a couple of years ago. And wherever you go in the world now, every speech pathologist will refer to modified diets and fluids in exactly the same way. Whereas previously, we all had different terminology for thickened fluids and modified diets. So this has really helped to streamline all of those terminology and processes. So particularly in Australia, if we've got people floating around hospitals and in the community, we're all using the same terminology. You'll see on this diagram that we've got fluids on one side and food on the other. And it moves through from the thinnest right through to the most normal. So we've got thin fluids, and then we're moving through the levels of thickness of fluid right through to the most thickest of fluid, and then moving across to options like puree or soft and bite size, or just a normal diet with some slight modifications. So speech pathologists that work in area of dysphagia will have very good knowledge of this and very good knowledge of what each level means and how we can tailor that to a particular person. Now, we know that people do not fit into boxes, particularly with Parkinson's, because every person with Parkinson's is different, and within a day, the symptoms are different. So often we need to come up with a plan that will enhance that. So sometimes it's looking at, okay, let's look at maybe doing mildly thick fluids with your meals, because that's when you get most fatigue, and that's where you're coughing a lot when you're eating and drinking. And for the rest of the day, you can have normal thin fluids as long as you're upright and you're sitting in a really well supported chair, and you're taking small sips one at a time. It may be that we say a soft and bite-sized diet is the safest option, but someone still really wants to have a packet of chips because that's their favorite thing to have. And so we say, okay, well, if that's something you really want to have, then let's incorporate that into your day, but have it when it's going to be as the safest possible time for you to have that. So when you're working in this area, it's really important to be flexible and to work with the family and the person, particularly with Parkinson's, around what it is that they would really like, what is going to be sustainable and realistic, because we know once we start modifying diets and fluids, we can then start to see people refusing to drink because they don't like thickened fluids, or refusing to eat because they don't like it modified or tampered with. So it's finding that balance of safety, making sure people are still enjoying and eating and drinking, but having some kind of compromise, being able to allow people some freedom of choice around what it is that is really important to them. So I always try and address meal times from a safety point of view, but also making sure people can enjoy food and fluids. And as I've mentioned, we need to make sure that we're upright and well supported and that we can easily access the meal. We know that taste can change with Parkinson's. So sometimes adding extra flavors or spices or herbs, chili sauce, whatever it is, to enhance the flavor, to enhance the desire, the taste, to want to actually eat. If they don't feel like eating, but the flavors there, it might just get the taste buds going. Adding sauces to help the food sort of slide down. We know with dry mouth, we're not getting enough saliva to help to form that ball of food to help it go down smoothly. So we're adding sauce to help with that. We're sort of doing the job of the saliva that we don't have. Things like bread can be really difficult. It's very dry. It can have a really dry crust. So, having a think about taking the crust off, what kind of filling is going into that bread to help to add some moisture to make it a little bit easier. Just those sorts of things. Having fluids at a mealtime is really important. Again, it helps with clearing any of that residue that we can't clear, anything that's sticking that we can't clear with our tongue, or, because we don't have the saliva to push it back. And just, alternating that fluid and food to help everything sort of push all the way through that whole process that we talked about, making sure that nothing's sticking along the way. Sometimes eating smaller meals or snacks more frequently if, the appetite is really poor or there's lots of nausea or that feeling of being sick when a meal is presented. Sometimes having that looking like a smaller snack size option is not so overwhelming for people. And so therefore, they're more likely to eat something presented in that way. As well, having things presented, rather than things like soup in a bowl with a spoon, having soup in a cup that you can hold and drink rather than sort of struggle with the spoon and the bowl and having soup going everywhere. Having meals presented in a snack box or a lunchbox style can be quite helpful. Just again, that different presentation, it doesn't look as overwhelming as a big plate of food. That can really be helpful for people too. And once we start to get into the texture modified diets, we sort of need to be a little bit more creative with what we're doing, particularly for things like a minced moist diet or a puree option, because they can start to look fairly unappetizing. So sort of being creative with some of those ways to entice and keep people interested in their food. Okay, so medications. This is something I get asked about, I think, 100 times a week. It's something that many people have difficulty with. You don't have to have a swallowing issue to have trouble swallowing medications. It can be an issue completely on its own. We're trying to essentially swallow something whole, which goes against everything that the brain tells us not to do. The process of swallowing initially always includes that oral phase where we're working to break down a piece of food to get it ready to swallow. Essentially, with medications, we're bypassing that process. We're not chewing anything. We're putting a whole tablet in the mouth and telling the brain that we need to swallow that down in one go. As you can see from that picture as well, there's all sorts of tablets in different shapes and sizes. Some are coated, some are not. And so we've got this real variability in shapes and sizes, which the bigger tablets and the tablets that aren't coated usually tend to be the ones that are the trickiest. So how can we get a tablet down? Well, often I see people taking a whole handful of tablets in one go. Taking a tablet one at a time means that we're only focusing on that one tablet with a little bit of water, if that's how you take the tablet. If that one tablet was to go the wrong way, you've only got one tablet to deal with. If you've got a handful and you've taken them and some of them go the wrong way, you've then got 3 or 4 that are stuck and makes it much more difficult and dangerous. So always trying to take one tablet at a time. People's natural instinct is to often throw their head backwards to get the tablet down. By throwing your head back, you're actually opening up your airway into this sort of shape. So therefore, it's making it a wider entry for that tablet to go down the wrong way. We want to try and bring our chin down a little bit to our chest to try and protect the airway and make sure that we don't have as big of opening for that tablet to get caught. Trying something other than water. So people often assume, tablet with water, but sometimes the water is just not the thing that will work for that person. Sometimes it's soda water, sometimes it's orange juice, sometimes it's milk, sometimes that different layer of flavor or sensation with the soda water can help that person to be able to swallow that tablet down. Sometimes we have to talk to the GP or the pharmacist about an alternate form for that medication. Sometimes it's just, we've tried so many other things and nothing's working. And so we have to look at an alternate form, whether it's a chewable option, a liquid option, or whether we can disperse it in some water, or whether we can crush it. And we'll talk about crushing tablets shortly. Sometimes we can trick the brain into thinking that we're just drinking alone, and using a straw or a spouted cup can actually trick the brain to think that we're just drinking as opposed to taking a tablet. So sometimes just that process of having a straw and drinking from a straw with the tablet in the mouth can help to clear that. And Gloop, you may have seen this in the pharmacy or heard about this, but this is a product, it's a medication lubricant. It's specifically designed for people with medication dysphagia. It's a very slippery gel, and it has no known interactions with medication, which is really important, and we'll talk about that in a minute. The ingredients in this almost break down immediately once the tablet hits the stomach, and it doesn't impact on the absorption of medications. So often this is a product that people find quite helpful. And we'll talk about why this sort of product is more favourable to something like yogurt or custard or jam and things like that, where often we're told to mix medications with those types of things. So crushing medications. Sometimes people do this independently on their own because they just can't get the tablet down, so they think this is the next best thing. In actual fact, some tablets cannot be crushed, and we know that Parkinson's medications cannot be crushed. Those delayed release or extended release formulations just cannot be crushed, and for many, many reasons. The coating on a slow release formulation is there to protect the stomach, and so if we break that through crushing, we're actually then more susceptible to any residue from that tablet causing a really corrosive or caustic interaction with the esophagus and the swallowing pathway. So we can get ulcers, we can get caustic side effects where you actually get burning in the esophagus. So that's one of the reasons not to be crushing slow release formulations. And extended release formulations actually have a higher concentration of medicine within them. So if we're crushing them and then we're taking them, we're actually telling the body and giving that tablet in a much faster form than what it's intended. And so therefore the side effects is medication toxicity. And people have died from doing that. And cytotoxic medications can't be crushed because the particles can be inhaled. It can irritate your skin. So those sorts of things cannot be tampered with. So medications that can be crushed, and there are ones that can be safely crushed, it's about what you mix that tablet with. And there's been a lot of research in terms of crushing tablets and giving them with things like yogurt or custard or jam or puree fruit. And in actual fact, it's been proven that it changes the absorbency and the effect of that medication in the body. So for something like a pain medication that you're crushing and then taking with yogurt, it takes longer for that tablet to react in the body. Therefore, that person is often in pain for longer because it's taking that tablet a lot longer to disperse within the body because it's been taken with something that inhibits the absorption. Crushing multiple medications at once. I see this all the time, particularly in aged care, where all the tablets are taken put in a mortar and pestle, crushed all together and given all at once. Now think about the reaction to all of those tablets together. Tablets are supposed to be taken one at a time. They all have their different interactions and their purposes. And if we're crushing tablets all together, then we have no idea what is happening once we ingest all of that. And taste, obviously, crushing tablets, the taste of them can be pretty awful, let's be honest. And there are legal implications. So common law requires that the right medication is given to the right person at the right time, and the right dose is given via the right route. And that will be stated on the product. Now, once we start tampering with those sorts of things, we then considering that medication to be off-label use. And so therefore it increases the liability of any, harm that is occurred from taking that medication. So if medication's altered without first speaking to, say, a pharmacist or the GP, the greater liability lies with the person giving that medication. So how do we minimize that liability? Well, then we have to consult the GP and the pharmacist, and we need to document things really clearly and outline why we're giving things in an alternate form. We need to follow the evidence base, and we need to be safe, and we need to use effective practice. And we need to obtain consent to make sure that people understand that tampering with medications or crushing medications, if that's the only way that we can get this tablet in, there are consequences of that. So crushing tablets is really the last resort. It's the last thing we want to do. And we want to try all those other alternatives if we can. We want to try other ways of trying to swallow that tablet down, like what I talked about on the previous slide. We want to try and see if there's an alternative form for that tablet. And if we're really stuck and that's the only option we have, then we need to look at how to do that in the most safest of possible ways. And this book is something I use all the time. It's absolutely fantastic. It's called Don't Rush to Crush. And I would probably pull this book out 10 times a week, where I'm able to look up a medication. I'm able to look and see whether it comes in an alternate form. I can look and see whether it can be crushed, what it can be given with, and what's the safest possible way we can give that to somebody. And I can use that information then to educate, the family, the person that's having the difficulty swallowing. And then I can also liaise with the GP, and we can get a plan together around what's going to work best. So take home messages. If you have any concerns regarding your swallowing, just contact a speech pathologist. It can be very mild through to having, quite regular, coughing or discomfort or concerns. It's better to get on top of it early than to leave it. Because as we said, we don't want to get to that point where we're in a crisis and we're having to go to hospital. So getting on top of something early and putting in some strategies. If you're struggling with medications, don't take it upon yourself to tamper or, crush things or do things with your tablets that haven't been consulted with by your GP or a pharmacist or a speech pathologist with knowledge in that area. And if you're ever unsure, just ask the question, get some advice, and never think that, even just having a mild swallowing issue is something to, not take seriously. So thank you very much. I guess now if we have any questions, I'm happy to answer.